Okay, so let's think about this. A doctor diagnoses pneumonia. That's the disease, right? But what about the patient's fear, their exhaustion, their fight for every single breath? That's your world. So if the doctor diagnoses the disease, how do you diagnose the patient's response to it? Let's crack this code together.
We're going to break this down into a 5-step mission that'll turn you into a full-blown diagnosis detective. First, we'll define your lane, what's your job versus the doctor's. Then, we'll go from finding a single clue to seeing a whole cluster. After that, we'll build the perfect diagnosis. I'll show you the formula. We'll cover how to avoid the most common traps, and finally, we'll pull it all together to get you totally exam ready.
All right, first things first. Let's talk about the most important rule of the road. Understanding the difference between a medical diagnosis and a nursing diagnosis isn't just some academic exercise. This is about practicing safely, effectively, and honestly, legally. This is your scope of practice, and you've got to own it. So here's the core difference right here. A doctor diagnoses the disease, let's say pneumonia. That diagnosis, it pretty much stays constant while they're sick. But you're diagnosing the human response to that pneumonia, something like impaired gas exchange. And here's the magic part. As your patient's breathing gets better because of what you're doing, your diagnosis actually changes, even if the pneumonia is still technically there. See? It's dynamic, it's alive. But it's not always black and white. There's this gray area called a collaborative problem. Think of these as potential complications that you can't fix all by yourself, but you are the absolute frontline defense. You're the early warning system for scary stuff like a hemorrhage or a seizure. Your job is to monitor and then collaborate with the provider.
So in the heat of the moment, how do you tell the difference? Easy. Use this super simple but really powerful test. Just ask yourself one question. Can I, with my own independent nursing actions, prevent this from happening? If the answer is yes, like turning a patient to prevent a pressure ulcer, bam, it's a nursing diagnosis. If the answer is no, like you can't single-handedly stop a hemorrhage, then it's a collaborative problem. Your role then shifts from prevention to super vigilant monitoring.
Okay, pop quiz. Let's use that test. You've got a patient with a fractured femur. You know they're at risk for a fat embolism. Now ask yourself, can you, by yourself, prevent a tiny glob of fat from breaking loose and entering their bloodstream? Nope, no way. You can watch for it, you can alert the doctor the second you see signs, but you can't independently prevent it. And that makes it a collaborative problem. The answer has to be C.
Okay, so you know your lane. Awesome. What's next? Well, now it's time to act like a detective. You're not just a collector of random facts, you're gathering very specific clues, and you're always looking for a pattern.
And here is a huge tip for your exams and for the floor. You have to avoid the single clue trap. A patient tells you, "I'm short of breath." That could mean, anything. It could be anxiety, it could be heart failure, it could be a dozen other things. Jumping to a conclusion based on one clue, that's a recipe for disaster. You need more evidence.
So let's see how this works. You start with that first clue, shortness of breath, but you don't stop there. You start digging. You notice some ankle edema. You listen to their lungs and hear crackles. You ask about their weight and find out they've gained a few pounds recently. Now we're getting somewhere. You have a cluster of related data, not just one isolated clue.
And when you put that whole cluster of clues together, the shortness of breath, the edema, the crackles, the weight gain, suddenly it points to a single clear pattern. It's not random anymore. It's pointing straight to fluid volume excess. You've just found the pattern.
Let's try it again. You have a post-op patient, they're grimacing, they tell you their pain is a 7 out of 10, they absolutely refuse to get up and walk, and their heart rate is jacked up to 110. So what's the deal? Are they just intolerant to activity? Maybe. But is that the root cause? What is the one thing, the domino that's knocking everything else over? It's B, acute pain. The pain is what's causing them to refuse to walk, and it's causing the stress response of a high heart rate. If you treat the pain, the other problems are very likely to get better.
All right, detective. You've found the pattern. You've cracked the case. Now it's time to write the official report. And to do that, you need to learn the formal language of nursing diagnosis. It's called the PES format, and it's how you create a statement that's both clinically solid and legally defensible. First off, you got to know what kind of diagnosis you're even making. Is it problem-focused, meaning the issue is happening right here, right now? Is it a risk diagnosis? So the patient is vulnerable, but the problem hasn't actually happened yet. Or is it a health promotion diagnosis, where a patient is doing okay, but wants to get even better? So for the most common type, the problem-focused diagnosis, we use this simple little formula, PES. P is for the problem. That's the official NANDA-I label, like impaired mobility. E is for etiology. That's the related to part, the cause. And S is for symptoms. That's your as evidenced by data, the proof that backs up your claim.
Okay, everybody lean in for a second, because if you only remember one thing from this whole section, I want it to be this. The etiology, that related to part, it absolutely positively must be something that you, as a nurse, can treat. It has to be something you can directly impact with your nursing interventions. This one little piece guides your entire plan of care. It's that important.
Check out this perfect example of what I'm talking about. This is the related to trap. It is absolutely correct to say impaired mobility related to incisional pain. Why? Because you can treat pain. You can give meds, reposition, use ice. But it is totally incorrect to say impaired mobility related to multiple sclerosis. You, as a nurse, cannot treat MS, so any interventions you plan based on that will be useless. Getting the etiology right is literally everything.
Let's test this out. A patient who had a stroke has slurred speech. What's the right related to factor? Well, it can't be A because stroke is a medical diagnosis. That's the doctor's lane. It can't be D. That's just circular reasoning. The problem can't be related to the symptom. The answer is B. You can't treat the stroke, but you absolutely can plan interventions for facial muscle weakness, like getting a communication board or teaching swallowing exercises.
We are so close. You know how to build a diagnosis. Now let's quickly talk about how to keep it clean, accurate, and legally safe. Think of these as the rules of evidence that are going to protect both your patient and, frankly, your nursing license.
Here is your quick and dirty don't list. Just burn this into your brain. Don't use a medical diagnosis as the problem. Don't try to cram two problems into one statement, like pain and anxiety. They each need their own diagnosis and their own interventions. Avoid judgmental language like poor hygiene. Be objective and say something like inability to perform self-care. And finally, never, ever write a statement that is legally inadvisable.
Now, what does that mean, legally inadvisable? Well, check this out. A statement like risk for injury related to unsafe staffing levels might feel true in the moment, but when you write that in a legal document like a patient's chart, you're basically admitting to a systemic failure that creates huge legal liability for the hospital. Your job in the chart is to focus on the patient's treatable condition, not organizational politics.
Okay, final scenario. An elderly patient fell. Which one of these statements should you never, ever write in the patient's chart? The answer is pretty clearly B. It's pointing a finger. It's assigning blame and implying negligence right there in the medical record. The other options, A and C, they focus on the patient's actual condition, which is always the correct and legally safe way to go.
Okay, let's pull it all together. We have covered a lot of ground, I know, but it all boils down to a really simple, repeatable workflow that you can use on any exam and in any clinical setting.
Here it is, your 5-step detective process. Step 1. Gather your clues. That's your subjective and objective data. Step 2. Find the pattern by clustering all that data together. Step 3. Name your suspect. Interpret the pattern and validate it. Step 4. Write the official report using that PES format we talked about. And finally, Step 5. Do one last check to make sure you've avoided all those common traps and errors.
So, we've done it. We've cracked the code of writing a perfect nursing diagnosis. This is the critical thinking that has to happen before you ever do anything for your patient. So I'll leave you with this question. Now that you can precisely name the problem, how does that diagnosis point you directly to your priority intervention? To that one action that is going to make the biggest possible difference for your patient's outcome? Because that is the bridge to planning, and that is the true power of getting the diagnosis right.